Good afternoon, our dear participants, to today's webinar. Just to let you know, we'll start in about 2 minutes. Thank you all very much for joining us this afternoon. Good afternoon, ladies and gentlemen, and thank you so much for joining us this warm Thursday afternoon. My name is Victoria Moira, and it is my pleasure to welcome you to the third and final in the series of webinars that are looking at the learning around contraceptive use and timing in the post-pregnancy period. We have an excellent team in the house today to do justice, so we expect you to sit back, relax, and enjoy as we start. Now, the Post-Pregnancy Family Project, supported by Bill and Melinda Gates Foundation and the MSD for Mothers, is supporting Lagos State to increase contraceptive use among post-pregnancy women within the private sector. The project was implemented in 236 private health facilities. The post-pregnancy period commences when a woman is pregnant through the 12 months post-delivery. And this phase is considered to be quite important as it does provide opportunities to introduce women to family planning through the frequent contact with the health system, from the antenatal services to the delivery services, and of course, the postnatal care. And over the last 4 years, the project has implemented advocacy, demand generation, and service delivery interventions aimed at increasing access and utilization of post-pregnancy family planning services. Now, the webinar today seeks to provide you, the audience, with deeper understanding of how ideation around contraceptive use changes during the post-pregnant period. The ideation factors are related to family planning uptake, decision-making during the post-pregnancy period, preference for lactational amenorrhea method, the transition to other methods, and of course, the switch between the public and the private health facilities for a more efficient post-pregnancy family planning programming across the state, and of course, indeed in Lagos. Now, for us in Lagos State, these findings are very critical for understanding because they would help to guide and improve future program implementation in the state. And so it is my great pleasure to be moderating this webinar. Today, we have three excellent speakers who will do justice to the longitudinal study. But up first, we would like to welcome our keynote speaker for today, Yaduni Ulubode from the MSD for Mothers program. She is the in-country director. Now, Yaduni Olubode has, over the last 2 decades, worked across various sectors in Nigeria. She is an advocate for development of women and the youths as key contributors to the economy. As a consultant and the Nigerian director for MSD for Mothers, she is responsible for overseeing investments directed at supporting innovative, sustained improvements in maternal health outcomes through a mixed health system. Prior to being engaged at MSD for Mothers, she worked as a nonprofit leader in entrepreneurship and youth development, and she has also worked as a management consultant, designing and implementing a range of strategy and talent management solutions across both the public and the private sector. In this role, she facilitated the development and implementation of several capacity development programs in collaboration with the public and the private sector stakeholders and developmental background partners. Yaduni's background is in economics with an undergraduate degree from the University of Lagos School and a master's degree from the University of Surrey. She is also a certified change management professional. Yaduni, good afternoon and welcome.
Thank you very much, Dr. Moira, and good afternoon, everyone. I'd like to recognize especially representatives of Lagos State on the call, especially the Director of Family Health, Dr. Oludara, very ably represented by Dr. Victoria Moira, the Reproductive Health Coordinator. I'd like to also acknowledge the Bill and Melinda Gates Foundation, represented by Rodio Diallo, the Association of General Private Nursing Practitioners, AGPNP, the Association of General and Private Medical Practitioners of Nigeria, AGPMPN, and the private facility owners. I know they come under that umbrella, but I want to call them out and their dedicated team of staffers, because it's the work that you have done that we're so proud of, and we're going to be talking about today, analyzing and understanding the patterns therein. I want to acknowledge the project implementing team of the Johns Hopkins Center for Communication Programs, led very ably by Dr. Taiwo Johnson, our distinguished speakers, also part of the team, and you especially attendees who have made the time to attend today's seminar titled Contraceptive Use and Timing in the Post-Pregnancy Period. My name is Iyaduni Olubode, and I represent MSD for Mothers in Nigeria. MSD for Mothers is an initiative of MSD, the pharmaceutical. In the US and Canada, we are known as Merck, but in Nigeria, we're known as MSD. And in 2012, together with the Bill and Melinda Gates Foundation, MSD for Mothers made a joint commitment in support of FP 2020, the goals, and the Post-Pregnancy Family Planning Project. This project, implemented by the Johns Hopkins Center for Communication Programs, is one of the babies that was birthed from that commitment. This program was aimed at providing post-pregnancy clients with the information and services required to use family planning during this critical period in their lives. According to WHO, 60% of women who want to space their pregnancies have an unmet need, and women who have given birth are amongst those with the highest unmet need for contraception. This lack of access to contraception often leads to unwanted pregnancies and death related to unsafe abortions. And so the provision of quality and comprehensive family planning services is widely considered a highly cost-effective way to reduce maternal mortality and potentially avert up to a third of all maternal deaths by empowering women to plan and space their pregnancies. This has great implications for a country like ours that accounts for up to 20% of global maternal mortality burden. And over the past 4 years, the project has worked progressively to institutionalize family planning along a continuum with maternity and child health services in private health facilities. The frequent contacts with women during their post-pregnancy period with the health system offers a unique opportunity to address contraception and thus adequate child spacing and good health for both mother and child. And this project has worked closely in over 200 private health facilities using evidence-based and theory-driven demand generation and service delivery interventions to increase access and utilization of family planning services by post-pregnancy clients during antenatal, delivery, and postnatal services, including immunization. Now, local private providers, they deliver a significant portion of care, not just in Lagos, not just in Nigeria, but across the globe. And this is acknowledged by the WHO. Lagos, I think the percentage is about 60%. About 60% of the population are catered to by the private sector. And it's evident that to deliver on our sustainable development goals, especially goal number 3 of good health and well-being for all, and universal health coverage, we're going to need strong mixed health systems that are resilient and offer quality care. And therefore, the private sector plays a critical role in meeting this need and the preference of this state's growing population. Collecting and analyzing accurate, patient-centered, women-centered data for planning and decision-making is also critical, not just because of the relationship between ends and scarce means that we economists like to talk about, but also to ensure that programs are tailored to address specific gaps and specific needs of women. And so today's speakers will be sharing their findings from a panel study conducted amongst a cohort of pregnant women who are followed through their journey from delivery to the post-delivery period. And so as we listen, I invite you to share your comments and ask the critical questions that will help us improve programming designs aimed at reaching this crucial group of women. I thank you for joining the webinar, and I wish everyone on the call an enriching session. And with that, I'm going to hand over back to Dr. Omoira. Thank you.
Thank you very much. Well said. So good afternoon once again to those who are just joining us. Just before we meet our 3 brilliant speakers, I would like to let you know that we will be taking questions at the end of the presentations. So we kindly ask that you use the Q&A chat room to type in your questions. So let's meet our team of 3 up first. Mr. Kishewa Kiode is a regional advisor for research, monitoring, and evaluation at the Research and Evaluation Division of the Johns Hopkins Center for Communications Program, Baltimore, Maryland. He is a trained statistician and a public health specialist with more than 20 years experience designing and implementing complex monitoring and evaluation systems and research activities. He has supported and implemented research and evaluation activities in East, South, and West Africa. Over the last 10 years, his work has largely been focused on the use of data in program design, theory-based programming, including the applications in social and behavioral change communications, and of course, health system strengthening. He has conducted and published extensively on multiple health topics, including family planning, sexual and reproductive health and rights, amongst others. Mr. Kishewa Kiode, you're welcome.
Thank you, Dr. Mero.
Up next, we have Adedoyin Roberts, who has over 6 years experience in conducting research, monitoring, and evaluation related to reproductive health, education, and developmental programs and projects. She holds a bachelor's degree in demography and social statistics from the Obafemi Awolowo University and a master's degree in public health from the University of Ibadan in Nigeria. She currently works as a research monitoring and evaluation officer for the Johns Hopkins Center for Communications Program led post-pregnancy family planning projects. Adedoyin, welcome.
Thank you, Dr. Mara.
And last but not the least, we have Professor Stella Babalola. She's a professor and teaches health communications in the Department of Health, Behavior, and Society at the Johns Hopkins University, Baltimore, Maryland. She's also the Director of Research and Evaluation Division, Johns Hopkins Center for Communications Program. Prof has over 30 years of experience in behavioral research and has worked extensively in Africa, Latin America, and the Caribbean. In the last 5 years, her research has largely focused on malaria, family planning, and the risk factors for HIV in Africa. Prof, a very good afternoon to you.
Thank you.
Okay, so just before they start, a gentle reminder, we shall take questions at the end. Kindly use the Q&A functions. Thank you very much. Mr. Kinshewa, over to you.
Thank you once more, Dr. Omoira, for that wonderful introductions. And of course, many thanks to our participants for joining us today. This afternoon, I'm going to be using the next 10 to 15 minutes to walk us through the overview of the PPFP project, the Post-Pregnancy Family Planning Project, and of course, with lots more emphasis on the methodologies, the methodology for the research, the panel survey that we are bringing to you this afternoon. When I get through that, Mrs. Robert and Professor Babalola will bring us the key findings, and then Prof will return to lead the conversations around the discussions. And then we will all come together, have a nice time asking questions and having a nice question and answer session. Quickly, just to bring to you, the post-pregnancy family planning project is a 4-year project funded by the Bill and Melinda Gates Foundation and MSD for Mothers. In Dr. Moira's presentation, she had defined what the post-pregnancy period is. And just to remind us again, the post-pregnancy period is a period from the end of pregnancy through 1 year post-pregnancy, irrespective of the outcome of that pregnancy. It could be live birth, stillbirth, or any form of outcome. The PPFP, Post-Pregnancy Family Planning Project, in the last couple of years, supported 236 private facilities in Lagos State to integrate post-pregnancy family planning into the MNCH continuum of care. The goal of the project was to increase contraceptive use among post-pregnancy women that are accessing services and care in the private facilities in Lagos. To integrate post-pregnancy family planning into the MNCH continuum of care, the project supports private facilities on how they can advise and counsel women that are attending antenatal care services on family planning. They also give capacity to them on how they can initiate family planning conversations with their spouses, even while they are still pregnant. For women who were seeking delivery services, the project supported private facilities on how they can counsel women on family planning, that is before they are even discharged from the hospital. The project also supports them to provide the immediate postpartum contraception for women who choose to start at that point. For women that are presenting for postnatal care and that are bringing in their babies for immunization, the PPFP project supports these facilities on counseling, on how they can counsel these women on family planning. And of course, how they can, they sometimes also support them to offer contraceptives that they choose to take up at that point. For the project to achieve this, the project implemented a 3-pronged intervention model that had been tested by previous JHUCCP projects like the Nigerian Urban Reproductive Health Initiative. This model has been used and tested to be effective. And so the PPFP project implemented this 3-pronged model as well that has these 3 elements. The advocacy bit is meant to create an enabling environment for demand and service delivery generation activities to strive, to thrive and succeed, and also engage with stakeholders on conversations around family planning. On the demand generation leg, the project implemented data-guided, theory-driven demand generation activities using multi-channel approaches to reach its audience. At the service delivery level, the project worked to strengthen access to family planning services and improve quality of services across the private facilities that it is supporting. All of these are wound around the ideation model. So the question that comes to mind is, what is ideation model? What is ideation? Ideation refers to the beliefs, ideas, and feelings that people hold about specific behavior. In this case, family planning use, contraceptive use. The model further states that when we change people's ideational factors, that we would have changed their behavior. So as we change the additional factors that people hold, we would be improving on their chances of adopting that behavior, in this case, contraceptive use. In the last years, up to 10 years in Nigeria, that the project at the JHCCP have been implementing family planning program in Nigeria through the Urban Reproductive Health Initiative, and through other work in other countries. The project have identified several of these additional factors that it targets in its interventions. And as you can see on this slide, you can see there are several additional factors ranging from knowledge, myths and misconceptions, spousal discussion, and so on and so forth, that the project had identified. And the goal of all of CCP's project is really targeted at these ideational factors, because the model says that all of these factors work simultaneously, and the more of these additional factors you change, the more you are likely to see contraceptive use increase. So to gather data that will guide the design and implementation, including the evaluation of the project, the RMEL team developed this very interesting RMEL plan. This plan, as you can see, has 4 core elements. Data and results from the first 3 elements have been presented by this team in previous webinars. So today we are focusing on results from this last component, which is the panel survey of pregnant women, as mentioned by Dr. Moira. As you can see, there are a couple of elements under it, which includes the baseline assessment among ANC women, followed by the first and second follow-up that was done. And then lastly, the in-depth interviews were also conducted amongst them. So today, we are going to be bringing you these findings. Let's get into the methodology that was used for this study. I'd like to start with the objectives that we had in mind as we roll out this panel study. The first objective was that we wanted to explore and understand the knowledge, attitude, and norms, including the fertility desires of these ANC women. We wanted to know how they think about what happens with all these attributes that I've mentioned, so that we can better understand and program for them. Another objective of the study was that we wanted to understand the timing of contraceptive use, so that understanding can help in shaping programs among post-pregnant women. We also focused on identifying facilitators and barriers at each of those points for better reaching and for better programming. The third objective was that we wanted to assess how the participation of these women in this program has changed, especially their ideational factors, including their attitude, perception, norms, and of course, other attributes like fertility desires. We wanted to see how that changed, including intention to use. We wanted to see how that changed over time. And lastly, we wanted to have an understanding of their of the experience and their decision-making process, so that we can better program in that regard, and of course, offer some recommendations to other programs that will be implemented in this area. In terms of design, like I had mentioned, it's a longitudinal study among pregnant women that were booked for antenatal care in private facilities in Lagos. They were recruited during their first and second trimester. We wanted to make sure that these women had enough exposure, at the minimum 3 months in the project before delivery. And that's why we focus on these this period. We then followed up on them in interviews at 9 months and at 18 months after delivery. Lastly, we conducted in-depth interviews among 20 subsample of these women to better explore and understand some of the learnings that we have gathered from the quantitative data. Our participants were recruited from 40 of these private facilities that the project worked in across 16 local governments in the states. And then we conducted face-to-face interview at baseline when they were recruited, and the subsequent round of interview, the first and the second, including the in-depth interviews, were conducted using mobile phone. All of the women in the study were screened for eligibility to make sure that they are eligible. And the eligibility criteria, including that they must be in their first and second trimester of pregnancy, they must be between the ages of 18 and 49. We also included minors if they were married and if they meet the other criteria as well. We made sure that they were also those that have access to a cell phone, because we knew we were going to conduct subsequent interviews by phone. And then we made sure that they were registered or they were booked to receive ANC care, antenatal care in those facilities. All the women that were in the study consented to participate in the study. The study started with recruitment and initial face-to-face data collection in February of 2019. And then the first follow-up was in January of 2020. And the second follow-up was in September of 2020. We conducted these in-depth interviews in June of 2020. And we are currently analyzing this webinar this afternoon. Numbers in terms of those that were recruited and those that were participants that were recruited. I need to take my video out. My data is, my internet is unstable. Okay. So just to bring you the numbers, at recruitment and at baseline, we recruited 711 women into the study. That's in 2019. After the recruitment, by the time we followed up, we interviewed only 550 of them. We had lost 161 of them to follow up. The loss to follow up was due largely to change in contact details, refusals to participate, and of course there was one maternal mortality. At the second follow-up, we had lost another 11 to follow up, mainly by refusals. And at that time, we interviewed 539 women at the second follow-up. So I am going to invite to Mrs. Adedoyin Robert. Thank you very much for listening to me this afternoon. Enjoy the rest of the session.
All right, thank you, Mr. Akin. Thank you for taking us through the study methodology. The next set of slides will be speaking to the results, as Mr. Akin has said. So specifically, we'll be speaking to background information on women that were included in our study. We'll also see how contraceptive ideation has changed through the post-pregnancy period. That is from the time when these women were recruited into the study at baseline, all through the first and the second follow-up. In terms of age, the mean age of the pregnant women booked for antenatal care across the 40 study facilities was 29 years, and almost all of these women had at least secondary education. By religion, close to 90% of the pregnant women were Christians, and about 3/4 of these women considered themselves to be strongly religious. Also, one thing that is interesting to say is that 95% of these women were married. And of course, these were the women that we met at the study facilities at the time the study began. And of course, they also were the ones that agreed to participate in the study. About 17% of the pregnant women either do not want their pregnancy as at the time when they got pregnant, or wanted to wait for that current pregnancy. So these women, we also asked these women their intention So for all the women, we wanted to know if they had the intention to have additional child or children in the nearest future. 18% of these women reported that they had no intention to have any more children in the nearest future. And for women, among those who have used a modern contraceptive before pregnancy, the major source for resupply for modern contraceptives for these women were majorly from pharmacies and from private health facilities. We would see that over a sizable number of them sourced their last resupply from private health facilities mostly. So during ANC, more than half of these women reported that the quality of the information around family planning that was received was not adequate enough. Only about a fifth of these women were asked about their FP preference after delivery or even told about side effects. One ask that is really quite important is how we can leverage this particular period, because this period is believed to be key to supporting a woman's choice when it comes to choosing the most suitable method for her after delivery. And also this is the period where we know that, yes, we can address those issues around misperceptions, around side effects, with respect to the particular method a woman may be interested in taking up immediately after delivery or even within the post-delivery period. And for awareness of modern methods, we see increasingly majority of the women reported to know at least one modern method. You see that from baseline to end line, that was at the second follow-up. 89% of the women reported to have known at least a modern method at baseline, and by the time it was the second follow-up after delivery, nearly all the women reported that yes, they know at least one modern method. And in line with the previous slide, seeing awareness for FP was quite high across the different follow-up points. Would also, a question is really that, do these women also engage their spouses on discussion around contraception? This current slide shows that by end line, at least 8 out of every 10 women included in this study reported that they discussed family planning with their spouses or partners in the last 6 months. We see that more than 3/4 of women reported intention to use family planning after delivery. And as for the time when they are going to initiate using a contraceptive or start using the method itself, we see more than half of these women saying yes, they would start using a modern contraceptive method within 3 months. And that 3 months covers from immediately after they deliver up to less than 3 months after the delivery of their baby. But really, does intention, having high intention, does it also necessarily translate to use eventually? So just to reiterate again on ideation, just as the previous speaker has said, that the more of the positive ideational factors that an individual, which is the woman in this instance, has, the more we can expect to change when it comes to a behavior towards contraceptive use. So we looked at knowledge. We looked at knowledge for modern contraceptive, that is in terms of level of awareness of knowing at least 4 modern methods. Also, we looked at a rejection of PPFP related meat. By this, it means if a woman is able to reject meat, the particular meat that using family planning within 6 weeks of delivery can lead to health problems. And if we look at the trend that we see before delivery and after the second follow-up, we see the level of awareness for at least 4 modern methods increased significantly by end line. At least, in fact, it doubled over the period. Also, for women who reject the PPFP related meats, that using contraceptives within 6 weeks delivery can lead to health problem. We also see that that also changed significantly. And for injunctive norm for PPFP, by injunctive norm for PPFP, we mean women who now have the perception that people in their community would praise them if they knew that they were using a modern contraceptive immediately after delivery. We also see that increasing as well from before a woman delivered and even up to the second follow-up period when these women were reached out to. We also see that those that now perceive that it is safe to use a modern contraceptive immediately after delivery, that also increased over the period that these women were followed up. Now this slide is the result of the marginal effect that is derived from random effect logistic regression of selected ideational variables on pre and peri-delivery variables. Our model was adjusted for age and education of the women. And of course, this slide in simple terms, it's simply describing the effects and the significance that would have that ideation that would have occurred if all women that was included in this study were exposed to the selected pre and the peri-delivery variables. So the pre and the peri-delivery variables refers to if all the women were exposed to family planning information during antenatal care, if all these women received family planning information at delivery, if all these women in this study discussed family planning with their spouses before pregnancy, or even if they used family planning at all at any point in time before their pregnancy. So now, if all those women, taking all the different variables one after the other, if all the women in this study were to be exposed to family planning during ANC, or if all the women received family planning information at delivery, or they happened to have been highly exposed to PPFP program messages before they delivered their baby, the level of awareness for at least four modern methods would have been increased by 8 percentage points, 14 percentage point, and even 19 percentage point respectively between baseline when these women were recruited and the second follow-up period, that is when they have given birth. And in fact, this is very, very statistically significant. Also, if all pregnant women were to have received family planning information during ANC, then the percent that would have perceived that modern method as safe to use immediately after delivery would have also increased by 9 percentage points between baseline and the second follow-up. And of course, this is also very significant. So when I say statistically significant, it just simply means the more stars that you see beside each of the variables that I mentioned, it means that is how significant those variables are. That is how significant the increase or the improvement in ideation would have looked like. Okay, so as I begin to wrap up, let's also look at the other variables. So it's similar to the explanation for the previous slide. If all women that were included in this study received family planning information at delivery or even used a family planning method before pregnancy, then injunctive norm in this instance means women who perceive that people in their community would praise them if they knew that they were using a modern family planning method after delivery, would have seen an increase of over 20%, precisely 20.2% between baseline when these women were recruited and then by end line. Also, if all women in the study used a family planning method before their pregnancy, then injunctive norm would have also increased by 5.8 percentage points. And what about the descriptive norm? So this implies women's perception that at least half of people in their community are using a modern contraceptive. So should all the pregnant women in her study, should they have received family planning information at delivery, there would have been at least 11 percentage point increase for descriptive norm. Also, with respect to those who are, if all of them were highly exposed to the different PPFP programming messages, descriptive norm also would have increased by 7.4 percentage point, and that is also statistically significant. And lastly, if all the women that were included in this study had discussed family planning with their spouse before they got pregnant, then there would have been almost a 7% increase in the percent of women with the perception that at least half of the people in their community are using a modern contraceptive. So to further speak to the specific timing for contraceptive use and the type of contraceptives that women are really using in the post-pregnancy period, would hand over the next session to Professor Stella. But before she comes on, I know Mercy would want to take a minute or two for poll everywhere. So thank you for listening.
Thank you very much, Adedoyin and Mr. King. Those were lovely presentations. And if you're just joining us, a big thank you. Please be reminded that the Q&A box is there for us to pen down our questions, and they will be duly attended to. And we are gradually getting to some very interesting points that will be shared with us by Professor Stella. But before then, just to ascertain our level of attentiveness, we have two simple questions we'd like you to attempt. And they're being displayed on your screen. The first question says, how many times were the women in the study interviewed? Is it twice? Is it thrice or once? We can start answering. The poll will be closed in a few seconds. The second question says, the participants in the study were recruited from, is it 40 public health facilities, or is it 40 private health facilities, or 40 secondary health facilities, or is it all of the above? The poll will be closed in about 10 seconds, so I will start the countdown. Let's keep voting. And 8, 7, 6. Let's keep the voting coming. Please make sure you pick something. Let's keep the votes coming in. 5, 4, 3, 2, 1. Okay. And we are ending the poll right about now. So I'm sharing the results, and a big thank you to everyone that voted. The first point of contact with the women was physical, and the other two follow-up visits were via telephone, as mentioned by Mr. Aki. So the correct answer is thrice, 3 times. Yes, so the women were interviewed 3 times. One was physical, and the other 2 were virtual via the mobile phone. And the second question, the participants in the study were recruited from, the correct answer is 40 private health facilities. And as you can see, most of our audience got the right. So a big thank you, and those were amazing responses from everyone. Please don't forget, as we continue the presentations, we'll take the last part of this presentation from Professor Stella Babalola, who will share with us some very interesting points, as I've earlier mentioned. I'll hand over now to Professor Stella as we continue.
Thank you, Mercy. So I'm going to be talking about the timing and the type of methods that women use in the post-pregnancy period. Can I have the next slide? So the question now is, when do women start to use contraceptives of whatever, of any type, in the post-pregnancy period? We see that most women will start using a method within 12 months of delivery. But also we see that very few use a method in the immediate post-pregnancy period, that is immediately after delivery, and even within 6 weeks of delivery. The most likely time for women to start using a method is between 3 months and 12 months. We also see that very few actually adopted a method for the first time in the post-pregnancy post-pregnancy period after 12 months of delivery. And very few among these women were yet to start, relatively few, about 16–17% were yet to start a method at the time that we re-interviewed them, which was between 11 and 21 months after their child was born. Now, the question is, what methods are they using? And we see that the method that the women were using differed by whether or not they started early, that is within 3 months of delivery, or they started a little bit later, that is between 3 and 12 months. So for those women that started within 3 months of delivery, we saw that only 1.7% adopted sterilization, which is probably not surprising given the context. About 10% started using a long-acting and reversible methods, that is, the IUD or the implant. About a little bit short of 30% started using a short-acting method. I have to say that mostly here are condoms, male condoms. About 15% started using standard days of rhythm. LAM was not very popular here among these women. And withdrawal was very popular and was reported by 42% of the women. Now, if we focus our attention on the women that started between 3 months and 12 months, we saw that, sterilization was reported by very few, which means that, whoever would adopt sterilization actually is likely to have done it very early, probably while they are still in the clinic within 3 months. We also see here that long-acting and reversible methods had increased in prevalence, from 10% among women that adopted a method within 3 months to 15% among these women that adopted a method later. We also see that short-acting methods have also increased in prevalence. And we saw that, standard days and rhythm, both of those methods have decreased in prevalence, and withdrawal has also decreased slightly, but significantly so. So there are differences depending on the time that the woman would adopt a method. Now the question is, why is it that women tend to delay use of modern methods in the post-pregnancy period? Yes, they would eventually end up using, many of them will end up using a modern method within 3 months, within 12 months. But why is it that they were not starting early? We had evidence from the qualitative research, the in-depth interviews that we conducted after was not one of them. But after some time, I just thought about it and felt I should do it so as not to get pregnant unintentionally. Then there was also, for some people, it was, for that immediate or, early in the post-pregnancy period, they are a bit cautious. There is preference for folk medicine and other methods. For example, this woman that was yet to start a method said that I have a goal, which is, herbal mixture that I drink. Immediately after, immediately I have sex, I use flagyl. Flagyl is an antibiotic, so that it will bring it out. And if I don't get flagyl, I will use Chelsea gin, which is an alcohol. The sachet type, I would drink one to flush it out. I'm just taking those for now. And we still get back to family planning. I will still use it to prevent me from getting pregnant. So this woman knows that, there is a need, but, they did not feel comfortable at that time to go for family planning. We also saw that, for some people, it was the fear of negative reproductive health consequences. Specifically, the belief that, women on family planning might have difficulty conceiving in the future. For example, there was this non-user that said, no, I have not done anything to prevent me from getting pregnant because I already made up my mind, even if I'm going to be on family planning, it will be after 2 or 3 kids. Somebody told me that when she dated, that is when she did family planning, and wanted to conceive after the removal of the contraceptive, it took some time for her body to adjust back to normal function. Another non-user said, people said I should give birth to all the children I want before going for family planning because I might do it and not be able to get pregnant again, which I listened to. I'm still thinking about it in the next 2 months. She was saying that she'll probably do it in the next 2 months. Now the question is, what are the women currently doing? That is, some 11 to 21 months post-pregnancy. First of all, we see that the majority are doing something. So at least, 71% of them are doing something. But what is it that they are doing? The majority are using a short-acting method. Some about 1/10 are using long-acting and reproductive and reversible contraceptives, and about another 10%, another 1/10 are using standard days method or rhythm. But we also want to note that that about 81%, almost a third, are still using withdrawal. So that's something to take note of. Now, yeah. So now the question here is, what are the factors associated with early adoption of modern method? By early this time, we simply mean that they started using a method within 3 months of delivery. Now we see that marginally using a modern method before pregnancy was associated with use of early adoption of modern methods in the post-pregnancy period. That it increased the odds by 64%. We see that the belief that modern methods are safe within 6 weeks of delivery, double the odds of adopting a modern method early in the post-pregnancy period. And the belief, the injunctive norm, or the belief that people in our community would praise her if they knew she was using contraceptives soon after delivery, almost I have to say, the model that we reported here are just any other things that we did not find significant, including exposure to family planning messages at baseline, using rejection of myths, the belief that high level of contraceptive awareness at baseline. They believe that modern methods are safe, within 6 weeks, which we find to be significant, and exposure to family planning information at delivery or during the ANC. All those were not found to be significant, but these were found to be significant, and we are going to discuss that. What exactly does that mean? So then, putting all of this together, what exactly are the learnings, because we have great learnings from this project. We have great learnings from the project. We saw that, the project was effective, very effective in changing ideation. We saw that, there are still some things to do. For example, one thing that one learning is that intention to use contraceptives within 3 months of delivery was high, was very high during pregnancy. Women, about 55% of them said that they were going to use a modern method within 3 months. But unfortunately, this intention did not translate into actual behavior. Now, the implication of that is that maybe providing information about family planning during A&C and at delivery is not enough. So it is not just about providing information about A&C. To be effective, health providers should work with pregnant women to make what we call implementation plan. That is the if-then, I'm going to do this at this time, and these are the steps I will take, and this is the method that I will use. So they need to work with pregnant women to make implementation plans for when to adopt a contraceptive method and which contraceptive method to use. In the process, working one-on-one with these women, not just giving health talk, not just giving family planning information as part of our health talk. The providers will need to address barriers. They need to personalize this message to the women and address barriers that the women, perceive to use of family planning early in the post-pregnancy period. Use of modern methods, especially LAC, is not very common within 3 months of delivery, which means that we need to put more efforts into strengthening the efficacy of women to adopt the most effective methods in the immediate post-pregnancy period. These efforts will include not just educating women on the benefits of these methods, which is a good thing to do, but also addressing the concerns that they may have about these methods during pregnancy and at the point of delivery. Next slide. We saw that more than half of the women said that they were not offered adequate information during A&C. Now, the question is, what exactly do they mean by adequate information? But whatever they meant, they believe that they did not get enough information to allow them to make an informed decision. So programs will need to continue to strengthen the capacity of private sector providers to offer quality information that goes beyond increasing clients' methods awareness. Relevant family planning information should be provided not just as part of a health talk, like I said before, but during one-on-one counseling, so as to enable personalization of the information to the woman's unique situation and information needs. We saw that 1 in 5 pregnancies were not intended among this group of educated women who live in Lagos. Most of the unintended pregnancies happened while the women were not using any effective contraceptive method. So promoting use of modern methods, especially long-acting reversible methods to all women, should continue as a priority. So it's not just for post-pregnancy women, but for all women. Exposure to program communication messages and receiving family planning during A&C and at delivery led to improvement in ideational variables. That is a fact. That is one of the key findings of the study. But we saw that these interventions, however, did not appear to have led to contraceptive adoption early in the post-pregnancy period. If we look at any adoption at any time during the post-pregnancy period, we find a link, but not early in the post-pregnancy period. And of course, the dynamics are different. These mixed methods underscore the need for messages that go beyond information provision, that goes beyond correcting misconception, to use personalized, persuasive methods during A&C and delivery to address specific concerns and information needs. Next slide, please. We saw that discussion of contraceptive use with spouse before delivery, the belief that modern methods are safe within 6 weeks of delivery, and injunctive norm about PPFP as significant predictors of early adoption of modern methods. And these are the variables, the additional variables that programs should target. There should be a focus on these additional variables as part of a more comprehensive approach to promoting PPFP. We also saw that, use of withdrawal remains quite popular among these educated women, whose husbands are most likely also educated or even more educated than them. The reasons for this finding are not completely clear. More research is needed to better understand preference for withdrawal among these women in spite of their relatively high level of education. And I believe that this is where we stop, and we will take questions and answer them. Thank you for listening.
Excellent job, Prof. Excellent job. And to the other members of the team, we've had a really good time listening to you. We will now take some questions and answer questions for the panelists. We kindly ask that you use the Q&A function. But just, 3 things Prof has said, just to say, adequate information, one-on-one with our clients, and of course, to come up with an implementation plan for our clients as well. Thank you so much. Okay, so first question from Ikenga Esther Oyenye. It says, good afternoon, ma. I had a client who complained of using an IUD after 6 weeks of delivery. She started noticing her boost. I presume this is her breast getting smaller, and she started growing thin, and her husband advised her to remove the IUD. What could have been the solutions, because 3 clients have the same complaints? Prof.
Okay, this is a question I will not attempt to answer because, I'm not a medical professional. I think, but I do not know anything in literature that links IUD to this complaint. But I don't know if there is somebody, with better medical background than me.
Thank you very much, Prof. I think Dr. Motunde will answer the question. She will respond also. Yes. In progress. She's already, I think, responding to the person while we take other questions. I can see another question has popped up. Yes.
Okay, so the second question says, what is the most preferred method by the women at baseline?
Okay. Aki or Doreen, do you want to answer that question, please?
Yes, so at baseline, thank you, Prof, and thank you for the question. So at baseline, most women before pregnancy responded, the most frequent, contraceptive methods used were majorly short-acting, which wasn't so much different. The condoms and injectables were really much preferred at baseline, and the natural method, the traditional method of withdrawal was also seen to really be prevalent at baseline when we asked about the previous method used for these women.
Thank you, Adedoyin. The same anonymous attendee also wants to know, at the end of the study, what was the most preferred method by the women?
Can you want to take that or doing?
Okay, so the method that women are now using, yes, it was in the last presentation, and it's still, we see that most women are still using the traditional, which is the withdrawal. And for the modern methods that are being used, we see short acting is still very much prevalent. Women are using condoms as well. I don't know if Mr. Aki wants to add to that.
No, I'm really having internet issues, so I didn't get any of the questions, but I'm back.
Okay. It says what was the most method used by women at the baseline and right now at the end of the study.
So I can jump in while Akin is getting ready. Yeah, if we are talking about the most used method, it's exactly like what Doni said. Most people are using short acting, and these are just those two methods, injectable and condom. Many people are actually using condoms.
Thank you very much.
And you know, the qualitative research revealed that yes, women are using condom not because they like it, but because that's what their husbands prefer to use. So again, we looked at the conjugal decision-making dynamics within the Nigerian family coming into play here.
Okay, so there's another question from Antonella Folabi. It says, what does the qualitative research say about withdrawal? It is surprising that the percentage is high.
Mm-hmm. Do you want to take that?
Well, okay, do you?
Oh, I can
Okay.
go.
Okay, well, I was just going to say that use of withdrawal method is not uncommon across board generally, especially in Lagos. Usually traditional method used in Lagos is very common, even across other population types. So there are lots of issues around modern method, especially from the perspective of what is safe and what is not safe. So in Lagos, as you can see from other studies, you will see that there are lots of people, going for withdrawal and of course other traditional methods. So it's a result that we find consistent across other studies in Lagos State.
Yes, and just to add to that, one of the main reasons from the qualitative why people are not using, why people are using withdrawal is because of fear of the other methods. They fear that, maybe they are not yet ready, maybe this will lead to this, maybe this will lead to that. And, they feel more comfortable with withdrawal, which does not involve putting anything or ingesting anything, putting anything on them or in them or ingesting anything. So there is that they are within their comfort zone with withdrawal.
Okay, thank you very much, Prof. Let's go back to the initial question we got that talked about having a client who complained of using IUD after 6 weeks and started noting her breasts were getting smaller and she started growing thin. And her husband advised her to remove it. Now, so Dr. Motunde has answered. The weight loss is not a common side effect of the IUD. Objective weight loss measurements should be conducted. Proper history taken, physical examination, and only necessary investigations will be key. Kindly reassure the clients. Thank you very much, Dr. Diane. I think we have one more question. Just to check. So from Victoria Denio, She says, can the introduction of Implano immediately after delivery affect the growth of the child?
I think Dr. Moti too signified interest to answer that. There was also one interesting question I came across in the chat box, Dr. Moira. I think it will go to Professor Stella or Mr. Aki, that are these findings also similar to findings from maybe other studies, perhaps what was carried out in the public sector? Are they also in line with it? Are there any similarities whatsoever?
Does that question, is it about in Nigeria or else?
In Nigeria, ma, comparing maybe if the findings are similar to what was obtained, maybe in other studies in the public sector, public and private now, comparing.
Okay. Yeah, go ahead, Akin, then now.
Okay, man. So yes, the answer is affirmative. We have conducted several studies in the public sector as well, similar studies. The results are very similar. There is both qualitative and quantitative. There are lots of issues around myths and misconceptions. There are issues of fear of side effects of modern methods. These fears and these learnings are across the population. In fact, in some of the studies that we did some sort of segmentation that was, some years ago as part of the family planning landscape analysis that was conducted for the BMGF,
Yeah.
Thank you very much.
Yeah.
Yes, okay, so Mr. Nathaniel Afolabi also wants to know, says, I see that the time to take up contraception is between 3 to 12 months. At what time do we have the highest uptake? 3, 6, 9, or exactly 12 months?
Okay, I can quickly answer that. I think it's post.
We learned that, the fear of side effects of.
Okay. Akin, you are saying something? Do you want to continue? Okay. So no, I'll just
So I don't know if it's my internet now. So I was just trying to say that, we've studied different groups, both right now in the private sector and in the public sector, perhaps not this very specific population, but across women across the different age groups and across wealth quintile, we have seen this very similar kind of results. Just want to put that on the table.
Okay. Thank you.
Prof, do you want to add to that?
Say that
Okay.
yes, I want to answer Nathaniel's question, which is, at what point is it 3, 6, or 9, or exactly 12 months? No, it is actually most after 6 months, they started to feel more comfortable. And that's when, many of them will start to use a modern method.
And just to add, some of the preliminary studies we did at baseline of this project, the qualitative piece, we actually understand that, the qualitative piece showed us that women, even men, were concerned that, early use of contraceptives might mix with the breast milk and may affect growth of babies. So it's something that really needs to be addressed in our future programs really more intensely.
Thank you very much. Okay, so some questions that have already been answered from Zoe Ajayi Majibi says, how can we make use of the CHOOS and the volunteer health workers, TBAs in helping out with family planning method, please? And so Dr. Motunde has answered saying, according to the task shifting and task sharing policy, CHOOS are allowed to provide balanced counseling and injectables, while the community health workers and the auxiliaries can provide timely counseling and referrals with adequate capacity building. Thank you. Any more questions? Okay, I think there's still one more question that Dr. Motunde is answering. It says, good day, everyone, and thank you so much for the lectures. My question is, a woman who had an IUD on for 5 years is now present at the facility with a pregnancy. What is the cost of the facility pregnancy, and what other methods should the client take after delivery of the baby? Well, okay, so that has been answered. The answer, I will read the answer as soon as that is ready. Do we have any more questions? While we're waiting for that answer, just to generally say that, well, across both public and private facilities, you find out that clients tend to have similar myths and misconceptions about family planning. There's this fear about the hormonals, and so you tend to find out that things like condoms and withdrawals are still very much in use. And some tend the preference to want to wait till after they've had all their children before they start using the more modern methods and the long-acting ones. It's something we've been able to find across board. But as usual, we just have to be able to work on providing adequate information and reassuring them as best as possible. Any other questions? Messi, have I gone through or have I missed out on anything?
Thank you, Dr. Moira. I think one more just came in right about now.
Okay.
So from the results,
Mary, okay.
Yes.
Mary Agoy, she says, thank you for the presentation. How do we deal with the drastic side effect of bleeding, especially assuming those using implants and injectables? She says, despite counseling and the use of OCPs and tranexamic acid. And then the next one from the anonymous attendee, it says, from the results, can we infer that more women are either taking up contraceptives or planning to, which is stronger? So can I sit to Prof to answer the last question, which is from the results, can we infer that more women are either taking up contraceptives or planning to?
I'm not sure I completely understand that, but you know what I know is that if you look at the proportion that are using the contraceptive methods among these women, it's much higher than what we have seen in Lagos State, you know, before in other studies. So, you know, like I believe maybe more than half of those women are using maybe more than 30% or 40% are using a modern contraceptive method, which we have not seen recently, which we have never seen in Lagos. So I think that to that point, this project has been a huge success in increasing the use of contraceptives among those women. What we have yet to see is, you know, more uptake of contraceptives in the immediate or the early portion of the post-pregnancy period.
Thank you very much, Prof.
Many women are using contraceptives.
Okay, so Prof has reassured us a lot more women are using contraception. We will just like them to use them slightly earlier after pregnancy than wait till the 6 or the 9 months or 12-month period. Any more? Messi, how are we doing?
Thank you, Prof. Thank you, Dr. Myra. We are doing just fine. So if the other clinical questions, Dr. Moti will get in touch with everyone. So I think at this point, if there are no more questions, we just want to use the opportunity to thank everyone for joining us today, and be rest assured that all the recordings and the resources on all our end of project dissemination series will be sent to everyone that registered for these webinars. And a big thank you goes to our key funders, the MSD for Mothers and Bill and Melinda Gates Foundation, especially to our keynote speaker today, Mrs. Yadaniola Bode, for joining us. A big thank you. And a big thank you to the state, because we collaborated on making this a huge success. Thank you, Dr. Moira, for ably representing the state and for your excellent moderation skills. So on this note, we have come to the end of the webinar. Thank you for joining us, everyone.
Thank you.
And for more information, if you'd like to know more information on the post-pregnancy family planning project, please feel free to visit our website. It's ppfp.ng. It will be posted in the chat box. You can also get additional resources from the site.